Move the phone a little towards your right.
To my right, like
Yes,
this.
a little. Yes, correct. Yeah.
Is that is that
Yeah,
all
this is
right?
perfect. Perfect. Yeah, perfect. No problem. Yeah. I'll just wait for a couple of seconds. So good afternoon, everyone. Wishing you all a wonderful, happy International Women's Day. This year's theme is to break the bias we face in the world, be it workplace or home. So, to commemorate with the International Women's Day, Dr. Plexus has organized this exclusive session where we shall be talking to one of our leaders from the field of IVF and infertility treatments. So, on behalf of Dr. Plexus, I would like to welcome Dr. Biplab Chowdhury. Welcome, sir.
Thank you. Thank you, ma'am, giving me the opportunity to talk in this August gathering, in this auspicious occasion of World Women's Day, International Women's Day.
So, before we begin today's session, requesting our audience to share any queries or questions if they have in the comment section. And today we shall be doing an interview with Dr. Chaudhary to understand various aspects of infertility as a global issue. Talking about Dr. Chaudhary, he's completed his MBBS in 1989 and MD and MRCOG as well. He's had training in UK as a senior registrar from 2003 to 2007. He's also been trained as a fertility specialist from Cardiff University in UK, and he's completed his FRCOG from London in 2017. In India, he's worked with various colleges and medical institutes as assistant professor, and is currently the assistant professor in IQ City Medical College at Durgapur. He's currently the director of Calcutta Cureline IVF Center, and since 2009. So it's a pleasure to have you with us, sir.
Thank
Um,
you.
Moving on to my questions for today. Sir, in this time and generation, we somehow celebrate women who are career focused or prioritize other milestones of their lives in their later 20s or 30s. So, are there any measures to ensure better advanced aged reproductive health for such women?
I mean, fertility treatment has come a long way. So that is in one hand. The other thing is like our global scenario is quickly changing, and over progressively over the last couple of years, more so because of the pandemic and also because of the women who are joining work and doing their post graduation studies and so. In that context, perhaps it is relevant to discuss one of the very vital things in a modern day infertility, which is ovum freezing. So, we'll quickly come to the context of ovum freezing because perhaps that's where the key treatment for women should be in the coming decade or so, because more women will join and pursue their careers. So, ovum freezing will be more and more relevant. And because of the technological advances, we are in a position to freeze the eggs before you could plan your pregnancy at some point of your time, say maybe 10 years down the line, and then perhaps take them out and get yourself pregnant at a convenient point.
Sure, sir. Now, in addition to that, are there any measures to improve or sustain age-related oocyte or embryo competence?
Well, what you need to be aware of, I mean, being a modern day woman, is that your age is equivalent, your age, I mean, is equivalent to your biological age. So if you are, say, 34, 35, the age of the egg is also 34, 35. So what we have seen in the context of India is that fertility levels go down quite quickly after the age of 35. It's not like 40 years, which is at the age of 40 for the European women or a US women from the US. So our aging for the egg is perhaps starting and will go down quickly at the age of 35. So need to know this knowledge and keep that in mind. So if we are looking at pursuing a career or delaying pregnancy for some reason or the other, so you need to plan your pregnancy and know this fact that I am not the same as my European counterpart. So I'll have to work on my plans for pregnancy, if at all, in future. If that be so, then perhaps it is prudent to freeze all your eggs beforehand and then go ahead and perhaps pursue your PhD career and whatever post graduations and so on, and of course job, and then find a suitable time to get pregnant. You can always freeze your embryo also. If you have got a husband and in a stable relationship, you can freeze your embryo also. Because embryo freezing is more, embryo is a more stable condition, and you can freeze them well. And this we have been doing for a long period of time. But egg freezing has recently come in, and as I've said, it will go ahead and the coming decade will be the decade of egg freezing, as it seems.
Sure. So, my next question is coming to the medical protocols. So, talk to me about whether there are any current guidelines followed to treat female infertility.
I mean, I can divide it into some general things for any women to do, whether she would like to get pregnant or not. And that you all know. Healthy lifestyle, eat healthy, do your daily bit of exercise and yoga. And if there is any problem whatsoever, there should be early referral to the gynecologist or fertility expert if you are seeking pregnancy. Investigations early, treatments as appropriate early makes sense. What we get nowadays, if we are looking at PCODs, we know that lot of young girls get, they are suffering from PCOD, but very few people will come and, seek advice of the gynecologist for their disease. Maybe she's having irregular periods, or her hairs are falling down, or she's having severe acne and other things. But she's just, passing on to her, age and the years, and these are the things that happen anyway, things like that. But until and unless she gets married and comes back, that she's not now being able to get pregnant, is when we are getting PCOD, and when the disease has matured to a difficult level. That's what I want to say. So if you can catch the adolescent girls who are PCOD and you can catch them early, I mean, I shouldn't be using the term catch, but I should be saying you can diagnose them early. Then perhaps we can treat the disease earlier on and get her in a better position, better shape to alleviate all the problems of PCOD, including fertility.
Okay, sure, sir. So, I want to understand if there is any proven relationship between age of the couple seeking infertility treatment and the success rate. So, how important is the age factor here?
Age factor is very, very important, as you can understand. As I have said just a little bit ago, that for reasons which is perhaps genetic and also perhaps nutritional, that our girls, they get a delayed menarche. I mean, things are changing. We are getting early menarches nowadays, maybe because of the nutritional fact and our, as we call it, hypothalamo-pituitary ovarian axis. They get matured early, so you get early menarches. And that is what is in the European scenarios or the Australian or American scenarios, where the nutrition is good and you get an early menarche, and also late menopause, and their nutritional status along with the genetic conditions, we are different from them, and perhaps, as I've said, we are lagging behind about 5 years, so that if we want to get pregnant, then perhaps we need to know that, as I've said, that 35 is the watershed, age of 35 is the watershed. And whatever you want to plan, if you want to plan our pregnancy, we should do it before. And if we want to delay it, then we should freeze our eggs, say at the age of 27, 28, 29, 30, and things like that. So that if you come back at 39, you have got a frozen egg, which you have frozen at the age of 28, 29. So your age of the egg will be 28, but you are 38 at that point of time. So we can make that difference, and that difference makes that's a big difference of 10 years, where you get good quality eggs, because as you know, euploid embryos or the good quality embryos are the key to have a normal pregnancy without any miscarriage, and going ahead to have a live birth. So if we are looking at a 20-year-old lady, she has got a 100% chance of getting pregnant if there is no other disease like PCOD, endometriosis, and so on. So age factor is important, and you have to have this knowledge that this is what we are talking about. If we are looking at 35 and above, below, you can get pregnant easily. And if not, if you have to delay or for some other reason you're getting married late or something, then perhaps it is prudent to freeze your eggs.
Sure. So, sir, since you've been practicing for almost 26 years now, what are the most common complications that you encounter in infertility treatments?
Most common is I would say failures is the most common complication. Okay. You try for pregnancy, you don't get pregnant naturally, and then you don't get pregnant through assisted reproductive techniques like IUIs and ordinary IVFs, and then for ICSIs, perhaps you don't get pregnant because of so many factors. So that is failures and its stress of failures, along with the the mental conditions of the couples. That is very important, and that needs to be addressed. And also, there are few fertility related complications like ovarian hyperstimulation syndromes, where you get some fluid to be accumulated inside your tummy if we have got superovulation, and then there could be fluid in the lung and other things. It's a scary situation, but thankfully it is very rare, and it has got three varieties: mild, moderate, and severe. Mostly what we see nowadays is no ovarian hyperstimulation at all, or milder forms of OHSS, or moderate forms of OHSS. But severe forms have gone down because of the current protocols and infertility treatments which has come up in the recent years. Okay. So that is less. And third is the multiple pregnancies. Okay. Because we tend to give more than 2 or 3 embryos at a time, so that your chance or probability of getting pregnant increases. If those 2 embryos stays back, then you are carrying a twin. In that case, you get all the complications, may get all the complications related to twins also. You may deliver a normal delivery, have a normal sort of course of pregnancy also, but you may have complications of twins like preterm labors and blood pressure rise and things. So these are in short.
Yeah. So before we move on to my next question, we have a question from Dr. Chetan Kumar Prajapati, who says, how about the treatment of a patient who does not have eggs and is 45 years old?
And in a good world, you will have to offer her a third party IVF. where you have to have eggs from someone who's mothered a child and at the age of say 23, 24, 25, and you can have the eggs. And if the husband samples are good, then you can do IVF and put the embryos back for this lady who's 45, 46. I mean, a lot of the women who are at this age come to us and they have got different reasons for their not being pregnant at that point of time. One is their age, another is like, they may have lost a child due to some accident or the other. So they will look forward to have another child to carry on with life.
Sure. I hope that answers the doctor's question. Moving on to my next question for today. So, in terms of success rate of IVF in India, what is the rate, and what are the factors that affect this success rate?
I mean, statistically speaking, the success rate of IVF in India is around 35 to 40%. I mean, some people drag it till 60% and so, but I think the realistic success rate is around 35 to 40%, 40%, so to say. I mean, in short, when I explain it to my couples, patients who are visiting me, I tell them you got a 50-50 chance of getting pregnant in one cycle of IVF. What I'm talking about is a single cycle IVF. I'm not talking about 2 or 3 cycles taken together. So they have got this percentage of success. And of course, the success rate will depend upon so many factors. One is the age of both the partners, I would say. And other is the concurrent disease if they are suffering from, like age along with the PCOD women, or a lady who is suffering from endometrioma, or someone who has got tubes which are blocked and have got fluids in the tubes. So all these concurrent diseases along with their age will determine as to what will be their success rate. Of course, with one disease at the age of 38, 39, a pregnancy rate will not be the same. It will not be 35 success rate, I mean, 35 to 40% take home baby. So that will go down.
Okay. What now talking about chromosomal abnormalities? What is the incidence of chromosomal abnormalities in advanced maternal age groups in India?
I'll give you two examples and two statistics for this. One is the miscarriage rate at the age of 40 is around 40%. That's easy to remember. So even if you get pregnancy through natural pregnancy or IVF, you have got a 40% chance of losing that baby. Miscarriage in the first 3 months. So that is one statistics. Clearly goes on to show that if you've got an aged embryo, then that embryo is liable to be lost, and the chances are 40% chances are of miscarriage. This is because of aneuploidy, as we call it in medical terms, which is bad quality embryos, and those are not genetically competent, so they go on to miscarry. That is one statistics that spoken about, and another is your Down syndrome.
Okay.
You know that Down syndrome, the statistics is 1 in 100 at the age of 40. So you are already high risk for Down syndrome when you are getting pregnancy at the age of 40. I know there are a lot of prenatal diagnosis where you can diagnose Down syndrome, if at all, and terminate the baby if you would like to. But still, that's a big trauma because that is not done until 12, 13, 14 weeks before the results come back, and you unfortunately come back to be positive for Downs for this baby and perhaps would like to terminate. So that's why, I mean, these are the two statistics that will show that genetic disorders increase with maternal age. That is the miscarriage rate, 40% at the age of 40, and Down syndrome, 1 in 100 at the age of 40.
So now talking about patient education. So how can our healthcare practitioners, provide patient education for better successful IVF outcomes, especially dealing with psychosocial triggers which they face in the society?
I mean, very important nowadays is knowledge. As we know, every one of us, that knowledge is power. So if you know what you are looking for and what knowledge you want to impart, all of us, starting from the doctors, the nurses, and the counselors, the psychoanalysts, and the psychiatric counselors, and general physicians, gynecologists, we have to know that these are the statistics in the background that we have told. I have seen a lot of patients being referred from the rural areas, and in an average, they take around 10 years to come to us in a tertiary care center where they can sort their pregnancy. So, if I'm looking at someone who has got um, uh, infertility for azoospermia, that is, husband doesn't have any sperm, and he is also moving around in the districts and small towns without being referred for 10 years. That is the average. So they should have come at the age of 25 and are coming at the age of 35. And so that's how things are. I mean, the knowledge is not percolating. The doctors are also perhaps not referring them properly, or the patients are not being guided properly. So they come at a very later stage. And that makes our job doubly difficult because the women's ovarian powers falter, as I've said, after the age of 35, 36, 37. Things like that. So
Okay.
lot of podcasts, I would think, talk shows, awareness programs, and to address all these issues, the mental health issues, and the knowledge of fertility, and how we can help with modern day infertility treatment should be highlighted to mostly to the patient groups, and the awareness should percolate into the districts and the small towns of India. India being a big country, this is really difficult, but somewhere or the other, we have to form a team to say so, to voice our concern.
Sure, sir. Um, Now, talking about PCOS, I think you did mention about it in the previous questions. So, what are the current guidelines when it comes to infertility treatment for cases of PCOS?
I mean, as I've said, it's a big story, as you know. PCOS is a chapter by itself, if I would say. But
Correct.
obviously, I mean, what I tell my PCOS patients, I'll tell you, like, I don't know where you will stop. I mean, we have got treatments for PCOS, that's fine. Some people will fall pregnant automatically if they lose weight, if they are overweight. Some people will have medicines like oral medicines, some stimulation of the ovaries, and they can get pregnant thereafter with ordinary oral medicines and support in the luteal phase. And some people, they might not get pregnant at all, and they have got severe degree PCOS, which needs to be investigated and treated, and they will need oral medicines plus injections along with the oral medicines to see if we can stimulate the ovaries through injections and get them to get pregnant. If not, then perhaps they will need only injections from day 2 or day 3 of their periods, so that they end up having a few follicles, and then we can do some IUIs or IVF if at all, and then she might get pregnant. I mean, the story doesn't stop here, because even if we see a lot of eggs in PCOS, but the quality of the eggs are not very good. So the PCOS patients might end up having miscarriage at a later stage of their pregnancy. I mean, say around before 3 months and things like that, because the
Okay.
quality of the embryos are not good. So that needs to be addressed also. So for to start with, I mean, if the PCOS patient is overweight, she needs to lose a lot of weight before she contemplates pregnancy, because that will even improve the ovarian circulation, and then perhaps we get some better quality eggs, which with which they can get pregnant, and then perhaps carry on the pregnancy without being miscarried.
Okay. Sure, sir. This brings me to my next question. If you could elaborate on the indications and recent advances in techniques of oocyte cryopreservation With the limited data available, can it become an ideal fertility preserving alternative in India?
Yes, I think so. I mean, the technology is improving, and embryologists will be in a better position to answer this question because they are doing this oocyte freezing nowadays. And it is a good option for infertility patients, for the women who would like to go ahead and sort career options and do their studies, PhDs, and so on, as I said. And also for the patients who have got cancer of the ovaries or the
Okay.
reproductive organs. So before being given the chemotherapy and the radiotherapy to such organs, so you need to preserve the eggs and then go ahead and sort the cancer out. So in that case, you preserve your eggs, go back and get your chemo radiotherapy, and then when you need a later part of your life, then you can take the. So that needs to be addressed, and that is true for both male and female patients. I mean, if someone has got a testicular cancer, he can also preserve his sperms if some for freezing, and the ovarian cancer, she can also preserve her egg for freezing for future use. And that we have got made a lot of advancement in that. Previously, ovarian freezing used to be a difficult job. It's still difficult job, but the embryologists are doing a wonderful work. And perhaps, as I've said, the coming decade will be decade of ovarian freezing.
So, like you mentioned about, ovarian freezing. So, it is suggested that an ideal protocol for ovarian stimulation is important to ensure good yield of eggs. So, have you designed any such case-based customization protocol for your patients? If you could please elaborate on that.
Yes, ideal protocol is, I mean, it is not like one shirt fits all.
Of course, yes, yes.
It's different, and every human being is different, and you have to take the parameters into consideration: is their age, their weight, their height, their previous failures in IVFs, and their hormonal status, the ovarian power, and what is happening to the husband's semen analysis, and how good they are flat or not. General diseases also, like whether she's obese or not, she's got diabetes or not, suffering from hypothyroidism or not. So you have to take all things into consideration. We also extend our knowledge about the patient. Like, it's not like taking egg from from the patient and fertilizing it outside with the husband semen and putting it back. It's like looking at the whole thing at in a perspective, like whether the patient, what is her age, whether she's suffering from diabetes, whether she's got heart disease, any clinical manifestation of any chest symptoms. Like, recently we have come out of COVID and so many people have suffered from it, whether there is a lasting damage to the lungs. So all these things, whether the kidneys are functioning good, livers are fine or not. So all these things need to be considered before we put back the embryos, because if we contemplate pregnancy, then we need to have a fit mother so that we can get a pregnancy, and she could sustain our baby till 9 months. So that needs to be addressed also. So we have to see the patient in a holistic approach, and starting from individualization of protocols to their to the delivery, till delivery, we need to see that she does not suffer.
Sure. Okay. Um, Having talked about that, so what are the factors that are responsible to determine the best protocol for controlled ovarian stimulation?
Well, factors, as you said, it's the same. I mean, we all nowadays are doing controlled ovarian stimulation. We don't do hyper stimulation for nowadays. So we consider the age of. There are some protocols and charts where we put the patient's age, the quality of the eggs, the number of the eggs, where we call it antral follicle count. We consider the some hormones like anti-Mullerian hormones, and also the seminal parameters. We consider all of them and put them in an age bracket of, say, someone who is less than 35 years of age, young patient with a low count, or an older patient with a low count, some with a younger patient with a high count, and older patient with high count, and things like that. So we create these boxes and tick as to where they fit, and then start protocols accordingly. I mean, they've got their own medical terminologies, but that's how we individualize these patients and give stimulation.
Okay. Moving on to the next question. I think a lot of people have also asked this question. So, what is the long-term impact on health of children conceived after infertility treatments?
Can you repeat the question?
Yeah. My next question is. Hello. Yeah.
Yeah.
My next question is also been asked by several doctors on the platform. For example, I think Dr. Subhash Bhatia and Dr. Ravi S. They've also asked this question. Are there any long-term impact on the health of the children that are conceived after infertility treatments?
Well, the long-term effects does not seem to increase with the fertility treatment. Like, there is 1% chance of major degree anomalies for any pregnancies, and that is true with infertility treatment also. Major degree means heart anomalies, the kidney anomalies, and so on, the neural defects and all. And there is 2 to 3% chance of minor degree anomalies with any patient whatsoever, even if she's having a natural conception or infertility. So that chance will remain, whether we are doing IVF or IC or stimulation with natural protocol or some with medicines and so on. So that will remain. But it does not seem to increase per se because of the treatment protocols. But yes, we are doing ICSIs in some of the patients, and ICSIs is like bending the nature to certain extent, and sometimes we tend to put some broken sperms into the egg, because we are not being able to see. It's not that we deliberately do it, because they are all very minute structures which are not being seen under microscope properly. Even you have to have a large magnification for that. But even if that happens, there is a increased chance of miscarriage with these broken sperms, with fragmented DNAs of the sperms and so on. So, but they will miscarry because nature has got their own way of autocorrection. Most of it will, autocorrect, and then leave those who are absolutely perfect, at least 99% perfect, so that we get a healthy pregnancy.
So we have two more questions. So something about a very important part of infertility treatments, which is cost. We know that, people from the low and middle income groups have a hard time, they do suffer when it comes to such treatments and their costings. So are any developments underway to reduce the cost of infertility treatment so that, low and middle income couples can also benefit from it?
Yes, I mean, that's what I was trying to address. Like, if we are fertility aware, then perhaps the cost will go down drastically. So if someone is having blood sugar, which is quite high, for both partners, or she's obese, or the husband is obese, so to say, and got some other disease, and taking medications like psychiatric, antipsychotics, and so many other things. I mean, if we plan that well, if we control the sugar, if we reduce our weight, and control the antipsychotic medications to a lowest level, and take folic acids and so on and so forth. I mean, so whatever we do healthy, then perhaps when we are contemplating pregnancies, then we don't have to go for multiple, IVF
cycles,
tries, and it's like so many centers have come up, and they have tried to, do IVF in a hurry or a rush. Perhaps there is a business angle to it, I don't know. But if that be so, I would say or suggest that you plan your couple's well-being well beforehand, and then contemplate pregnancy rather than doing 2 or 3 IVFs. Perhaps if you do 1 IVF or IUIs, at least 3, then perhaps the cost will go down. Other things are like our stimulation protocols have gone down, as I've said, from very high dose of stimulation to controlled ovarian stimulation. So that will reduce the cost of medicines because the injections are costly. So if we reduce the number of injections, the cost will go down. The other thing is, which has got nothing to do with medicine, is your EMI schemes that have come through, which is good for the middle income or low income groups, where they don't have to pay the whole thing at one go, and they can give some money and then start with the EMI scheme for 10 months or 12 months at 0% interest. So that is also another thing. Other thing is the IVFs and infertility treatment in the government segment, which is being tried, and some of them are successfully running the show. I know AIMS and other places also are doing the same. So if that comes up in larger numbers, perhaps the cost will be reduced.
Sure. One more question. I think we often fail to recognize that. But how do special IVF treatment options available for homosexual couples like reciprocal IVF work? If you could talk about that.
Well, currently there is an ART law which is in the pipeline. It has been passed in the both the houses of parliament and will take place since from perhaps June onwards this year. So we'll have to see as to what they are suggesting. So we are waiting for the law currently without being judgmental about it.
Of course. Yeah. Understood. So I think we'll take one last question. So now, as a specialist, any shortfalls you think in terms of treatment, socio-economic factors, management of IVF patients or diagnostic clinics? Do you think any shortfalls that you see in your practice?
Well, yes. I mean, a lot of things have been done and a lot of things need to be done. As you can see, the success rate of IVF is only, as I've said, 40%. Whatever maybe the tall claims from, big infertility houses, but it's still 40%. So 60% job needs to be done. Even today, I can't say for sure, like, okay, you come to me and I'll give you a baby 100%. So if that be so, will that be, if that be so, so we have got a lot of work to do, scientifically speaking, from educating our patients, from the knowledge of our, nurses, the co-partners, the counselors, and also from India being a poor country and fertility treatment is being expensive. The costs have gone down, I've seen, but still they are expensive. So I think that needs a lot of work needs to be done also towards that goal, where we can improve our success and lower our cost at the same time.
So I think, sir, these were the questions that I had from my end. I think we did take also a couple of questions from the audience. So I would like to close today's session, and I would like to thank you for making time and giving out such valuable inputs in this discussion of infertility on the occasion of International Women's Day. So thank you so much for coming together here, sir, for this session. And to our dear audience, thank you for your loyal viewership, and we'll make sure if you have any more questions, we'll definitely get back to Dr. Chowdhury and get the answers for you. And please take care and have a good evening ahead. Thank you so much, sir. Dr. Chowdhury, any words from your end, sir?
Thank you. Thank you. My pleasure.
Thank you, sir.